Hello, welcome. This March and April, in just the first 6 weeks of the coronavirus, every single one of our states took some action to pass healthcare reforms to give providers greater flexibility in the way that they dealt with COVID. These were things like expanding the number of practitioners, removing regulations for equipment or beds, and also establishing telemedicine for people who are homebound and need to talk to their doctors. So this may surprise you, but all of these reforms are ones free market healthcare advocates have been promoting for years. Welcome to the Philanthropy Roundtable's webinar series. I'm Anna Bob, the Health Program Director at the Roundtable. We're joined today by some of the nation's leading free market healthcare advocates. They're going to talk to us about why these COVID reforms are so important and why they're good not just for the time of COVID, but for every time and all the time. We have scheduled a 60-minute call to talk with them today. And since all of them are extremely knowledgeable, we are going to be expecting this call to go at a very fast speed. But we're most interested in hearing from you and answering your questions. So please join us in this process by addressing us questions using your Zoom question and answer function on your application. And now please let me introduce our guests. We have with us Charlie Katibi, a healthcare policy analyst at Americans for Prosperity, where he's working on AFP's new multi-million-dollar advocacy campaign, which was launched in April and is called Healthcare Reimagined. The campaign was in the works before COVID, but is now very active in making temporary COVID waivers and reforms permanent. We also have with us Naomi Lopez, the Director of Healthcare Policy at Goldwater Institute. And as someone who's worked on healthcare policy at the federal level and in several states as well, she's especially expert on how federal healthcare policy affects states and also how state policy is often the best incubator for federal reforms. Also with us is Beth Ann Munford, a Regional Director at Americans for Prosperity, where she leads a team of committed staff and volunteers across 5 states. She's an expert in grassroots advocacy and coalition building. And we also have Kathleen O'Hearn, who's State Policy Network Senior Director of Policy Advancement. She has worked there for nearly a decade, and before that she was at Mercatus, and she is an expert on state policy and very passionate in advocating for the ways that states can bring the most transformational reforms to our country. So as you can see today, we brought you only the best, and we have a very packed call, so I want to jump right in. And Kathleen, I'd love to start with you. Can you provide us some framing and context on these COVID reforms?
Absolutely. Thanks, Anna. Well, hello, everybody. Thanks for having me today. So about 2 weeks ago, I gave my 2-year-old daughter ice cream for the very first time. Prior to that, she had always received cottage cheese, which I told her was ice cream, which I know might be criminal, but I thought it was doing the healthy thing for her. I want you to see Penny's face when she had ice cream for the first time. This is Penny having her first ice cream. And so most of you parents know that now that Penny has had ice cream, chocolate ice cream at that, there's no going back, right? You can't put that genie back into the bottle. She's gonna scoff at my healthier options. So right now we are in troubled times, tough times. And one of the silver lining of times like these is that disruption and innovation, they really go hand in hand. I mean, we've seen this play out throughout history. Our world changes, we have to change the way we think, we adapt, and we can't think about going back. We're not gonna go back. Heck, the first iPhone was rolled out during the 2007-2008 financial crisis. And life without our smartphones is now unimaginable. And as the coronavirus outbreak spread this spring, policymakers across the country really had some tough challenges, some critical challenges. How could we help the country get ready? How could we help our healthcare system get ready to meet the demand and stop the spread of coronavirus, to avoid as many deaths as possible? The answer: remove as many barriers as possible to unleash innovation. Now, over the last 3 months, states have taken massive action, as Anna mentioned, to remove state regulations to let health innovation really thrive. And just like with Penny and her ice cream, with so many of these reforms, there's no going back. The genie's out of the bottle. But that doesn't mean that we don't have an enormous amount of work to keep and expand these efforts, to really let innovation flourish long after we found treatment for coronavirus. Now, I hear this a lot in healthcare. I know what you might be thinking. Well, Obamacare is the law of the land. Congress is not going to really do much about it. And even at the state level, it takes 3 to 5 years, sometimes longer, to move any of these reforms from ideas into laws. But we're in the middle of a pandemic, and all of a sudden, this stuff is moving into law, not in years, but in days. So the ACA passed about 10 years ago, and that's when we started our healthcare working group. People were really discouraged, saying, the right has lost healthcare. But we knew states can and should be a mechanism for change in healthcare. So we pulled some of the brightest minds, some of the brightest experts, some of them are speaking today, to create a toolbox of policy ideas that would expand access, reduce costs, and provide better patient experiences. So when the crisis hit 3 months ago, we quickly evaluated those policies and identified the top 5 that would make a difference, that would allow states to rise up and respond to the threat using market principles and that sheer power of human innovation. And those 5 policies, scope of practice, just letting things like pharmacists give coronavirus testing, surprise billing, a simple notion that people should know what something costs before they get billed, certificate of need, which I know we're going to dive in deeper to today, stop allowing a government permission slip when it comes to getting health facilities and equipment, telemedicine, we have iPhones, let's use them, unshackling 21st century technology from these really 19th century regulations, and finally licensing, removing barriers for people to go across state lines, to use their talents across state lines. And those last 2, telemedicine and licensing, were the biggest boom we saw in all this. So I want to share one of my favorite pictures in all of this that I think really demonstrates the power. Now, this is a plane full of Georgia doctors on their way to New York City at the peak of the New York City outbreak. Now, what I love about this photo is these guys, they're heroes, right? They're going in to save lives in the middle of an outbreak. But the other thing I love about this photo is it wouldn't have been possible if New York hadn't quickly removed their licensing regulations via an executive order. This photo, these doctors going to the front lines, is possible because those state reforms were made and people's lives were changed from it. So initially we started seeing things like this, like removal of licensing reforms, expansion of telemedicine. And so we wanted to dig into the research and say, how expansive was this? Almost every state had acted on one of these 5 issues in some way, but during the time of crisis, how expansive was it? And here's what we found. 40 states within 17 days took executive action on one of those 5 issues. It was quick and it was effective. And the dots where you see these white dots on this map, this is where state think tanks actively played a huge role in driving home these reforms. In some instances, you had Democratic governors coming to conservative free market think tanks asking for ideas. They wanted to unbundle the healthcare system, make it to where they could respond to the threat. Now, if anybody is interested in our research data, we have a lot of slides with a lot of data and spreadsheets. I'm happy to send that to anybody who's interested. Now, all of this has really reformed and breathed new life into the healthcare landscape. Healthcare reform is happening through the states, and it's happening right now, and it's happening at lightning speed. I'm sure some of you heard that drumbeat for nationalized healthcare. It's louder than ever. In a poll Kaiser Permanente put out just last week, support for nationalized healthcare among Americans is up to 56%. Everyone in the states proves that we don't need nationalized healthcare system. It's a step closer. Now, here's the kicker with all this. It'd be easier if we were all done. That'd be nice. But many states have expiration dates on the executive orders that made these reforms possible, that made it possible for those Georgia doctors to get on a plane and go to New York City to help. State policymakers are really going to have to make these solutions permanent and increase the supply of healthcare for all Americans for this to continue. And much of this is going to come to fruition in 2021 legislative sessions. And the good news, our research, and as you saw on that map, the changes were very bipartisan. Red, blue, purple, they all had some kind of reform. So the ground is so fertile right now. And just like I don't think I'll be able to get Penny to go back to eating cottage cheese as ice cream, although I'm going to try. So many Americans have now seen the power of these reforms. I mean, me included. Earlier this week, I had a medical issue, and my doctor has since got an app that we can log into and log an issue and do a telemedicine visit. So I did even just a text. I said, here's my issue. Within 2 hours, I got a response, and they're like, seems like a simple issue. Here's your prescription. Wow, I didn't have to go to a waiting room with people like coughing COVID on me. And what a relief that was. I can't go back to the old way, and I bet most Americans won't be able to either. We really have to keep up this momentum. States have made such significant ground, but we have to fight in 2021 in the legislative sessions to keep it permanent. And we really have a huge opportunity to finally make some gains in healthcare. And we can't miss it because the door, it's going to close if we let it. So with that, I'll turn it back over to Anna and hear our other great presenters.
Thanks, Kathleen. I just want to clarify, so you think it's 2021 legislative session. What kind of prep do you think that the state think tanks are going to need in order to really meet their targets in that session? What kind of prep time?
Absolutely. So a lot of these ideas and a lot of these reforms have been in the works for years. So that's the good news, is that the policies are there. It's all about implementation now. So there's going to have to be a lot of legislative engagement, a lot of planning. What does that issue campaign look like? What does it look like to say, here's our action plan, and here's how we're going to move it? And of course, you know, I mentioned that poll number, 56% of Americans want nationalized healthcare. We want them to taste the ice cream, right? We want them to taste what free market, what that telemedicine alternative is. So that's a huge thing too. It's just getting that messaging right and putting mechanisms in place so Americans can hear the stories, can feel it for themselves of what the alternative is.
Thank you so much. We want to drill down into some of these issues now, and so let's do that. Let's take a closer look. Naomi, I'm going to turn to you. One of these issues is licensing. So why was it so important to free up licensing? And why is it something we still need to be doing after COVID?
Yeah, so thank you so much for having me today. The Goldwater Institute is based in Arizona, and we do policy work. We also have a litigation team, a national investigative journalist, and I'm really excited to tell you that back in 2019, Arizona became the first state to pass a law called universal recognition. This law basically says that if you reside in Arizona, if you cross the border from another state and move into Arizona, that just because you cross the border, you don't lose your skills, whether that be nursing or whether it be as a dental hygienist or as a carpenter or as a therapist of some sort. So really what this law did is it made it a lot easier. It cut a lot of the rules and red tape that prevent people from moving into a state from becoming licensed in that profession. Most people don't realize that there are usually hundreds of licenses required within a state. Multiple boards regulate different professions. And in fact, a lot of professions that you wouldn't really think would need to be licensed in some states are, like painters, for example. So this was the first law of its kind. Our general counsel, John Riches, drafted the original version, and like I said, it passed in 2019 and was signed by the governor. Since then, our universal recognition model has been introduced in multiple states. It is now law either as the full universal recognition law or as a scaled-down version for military families in 5 states, and it's been introduced in 20 more. The COVID-19 crisis has certainly slowed down the momentum for that bill temporarily, but we're actually seeing a lot of renewed enthusiasm as state legislators go back into session. The reason that this is so important is because when we take a look at healthcare, the supply side of healthcare is essential. We know that the supply of healthcare, you can have insurance, you can have Medicaid, you can have coverage, but if you don't have a willing provider, you cannot get care. Your insurance card is not care. It's actually going and seeing a provider that actually gives you access. We also know that whenever you allow medical professionals to practice at the top of their education and training, you actually free up more resources to provide care. And that's why it's so important. In the midst of this COVID-19 crisis, as Kathleen mentioned, we saw a lot of states take action to remove the obstacles for licensed professionals to come in at least temporarily during the emergency. This was done in a couple of ways. Healthcare is very complicated, as I'm sure everyone knows. It's regulated at both the federal and the state level. At the federal level, the Centers for Medicare and Medicaid Services, which is under the Department of Health and Human Services, allowed for medical professionals to be reimbursed even if they went beyond their scope of practice, beyond what was usually allowed within a state, for Medicare, Medicaid, and the Children's Health Insurance Program. That's why you saw such a rapid adoption of loosening these licensing restrictions, because that meant that where the state had authority for the rest of the healthcare system, it was all aligned together. And that's going to be really important going forward when you look at and think about strategy for how do you make some of these reforms permanent, or even move beyond the reform and go further in terms of reimagining the healthcare system. So in terms of looking at universal recognition, it covers many, many occupations, but it does include healthcare. We know in Arizona that we have now licensed new professionals by the hundreds, and some of those do fall under the healthcare industry. So we do know that it's actually having an impact, even just a few short months after passing this law. There are really important implications for licensing when you take a look at issues like telemedicine, which we're going to talk about more later. But the bottom line is that licensing has a direct impact on the access to care and the cost of that care. And it becomes particularly important whenever you look at rural areas, for example, or tribal lands, where there is a severe scarcity of providers able to provide care. In Arizona, a couple of years ago, we passed a scope of practice reform which allowed certified registered nurse anesthetists to practice at the top of their education and training. These are the nurses who have basically a graduate level degree education and are able to do things like intubation. This became particularly important in the COVID-19 crisis. We were able to waive out of a Medicare rule that limited their scope. And in the COVID-19 crisis, we immediately saw an uptake in certified registered nurse anesthetists practicing in rural hospitals in Arizona. They were able to intubate patients, give anesthesia, and really provide a critically important role in supporting those COVID-19 patients, where you might otherwise have to have an anesthesiologist, which really just aren't even there in those areas in many cases, unfortunately. So this is why these reforms matter so much. It matters where the rubber meets the road. Whenever we take a look at this strategically going forward, the Goldwater Institute will continue working alongside our Liberty partners across the country to not only get this legislation passed, in 5 states or introduced in 20 as we now see, but to make this universal recognition available across the country in all 50 states, and really to make sure that it is perfectly legal for someone who is providing care to do so at the top of their education and training.
Thank you so much, Naomi. Charlie, can I ask you to join us now in this discussion? And as you do, I want to mention that Anna Thompson has written us, a longtime friend of the Roundtable, and she's on the call, and she brought up something that I think we're going to talk about. She described the large special interests that are incented to resist these reforms and how they are responding. So I think that's something that we're going to all be covering, but it may come up in this next, topic that we want to drill down on. Kathleen mentioned they have 5 different reforms that they've identified as their priority areas. And we would be happy to talk about all of them today, but we decided we were just going to talk about 3. And you know, Naomi actually kind of talked about scope of practice in addition to licensing. So I'm glad you did that. So she kind of covered 2, but we're only going to talk really about 3 today in depth. And the second reform we really want to talk about is just such an important issue in healthcare, and has been so hard, you know, I mean, to make headway for so long. And it's just almost kind of remarkable that this COVID is, you know, presenting any opportunity to make some headway. So that issue is really certificate of need. So Charlie, can you please just kind of frame this for us and tell us why it's important to reform these laws?
Yeah, absolutely. So first of all, I just want to thank the Philanthropy Roundtable for inviting me and just giving me the opportunity to talk on this really important issue. So you're right. A lot of governors have really moved on these laws known as certificate of need laws. And what these laws do is they require a new healthcare company, whenever they want to build a new healthcare facility or add a new service within an existing facility, they can't just build it. They actually must first seek permission from a government board and prove to this board that the area that they want to build in actually needs these new services. Now, what makes these laws so dangerous, especially during a pandemic, is that these healthcare companies will often use these certificate of need laws and these boards to block their competitors from opening or offering new services. For instance, whenever a provider applies for permission to build a new surgery center or a new hospital, existing hospitals will actively lobby the certificate of need board to reject that application. And oftentimes the existing hospitals are the certificate of need board itself. So many certificate of need boards are actually staffed by the CEOs of healthcare facilities. For example, in Tennessee, 6 of the board's 8 members represent either hospitals, surgery centers, or nursing homes. And in Michigan, over half of the state's certificate of need board actually represents hospitals. So these boards clearly have a direct financial interest in blocking new facilities from providing patients additional choices. And that's exactly what these boards do. Since the 1990s, economists have found that states that enforce these laws have fewer hospitals, fewer ambulatory surgery centers, dialysis clinics, and long-term care facilities. And most dangerously, especially during the COVID pandemic, these laws have prevented hospitals from adding new intensive care beds to care for more patients. So these states that have been enforcing these laws, they have about 131 fewer beds for every 100,000 residents. So as a result, these states have fewer hospitals, and the hospitals that are there have fewer hospital beds available to actually deal with the surge in COVID patients that are arriving at their doors needing care. In fact, researchers from George Mason University actually found that states that impose these barriers are twice as likely to run out of hospital beds. The average CON state is going to be short of about 8,000 ICU beds that would have been needed to properly care for these patients. So these laws have clearly made essential healthcare services a lot less available, and it's incredibly harmed patients. Now, fortunately, as you mentioned, governors are reacting incredibly quickly to deal with these laws. We've been fighting, Americans for Prosperity has really been fighting an uphill battle to remove these laws for years now, and it's really been fortunate that about 21 states have moved to waive these certificate of need laws for services that could help COVID patients. This has been happening in red states like Iowa and Tennessee, but it's also been happening in blue states like New York and New Jersey. And going forward, Americans for Prosperity is going to be really urging lawmakers to be making these changes permanent. It's going to be up to us to really remind them that these laws were not serving patients before COVID and definitely not serving COVID patients right now. And we really need to be doing this for several reasons. One is that it's very likely that this pandemic is going to worsen America's healthcare problems over the long run. We really don't know how long COVID-19 is going to be threatening communities, and hospitals and nursing homes are really going to be needing this flexibility to deliver a lot more care to infected patients. And another thing to keep in mind is that a lot of the problems that COVID patients have been suffering from a lack of healthcare access as a result of CON laws. Patients across our healthcare system have been suffering from this because certificate of need laws have been imposing restrictions across the spectrum. For example, states have been imposing certificate of need laws on hospice care facilities, dialysis clinics, and even when a hospital wants to add a new MRI machine or CT scanner, they need to lobby the certificate of need board for permission, and their competition will often use this process, as I mentioned, just to prevent them from adding these services. And the result is always the same. There are fewer services and fewer facilities available to care for patients in need, and hopefully we can be working with lawmakers to really make these changes permanent.
Thank you so much. That's terrific. So basically, there's just incredible cramping on flexibility that these hospitals need right now. Not to mention the fact that it just seems that, as Kathleen said, you need a permission slip to build a new hospital, or even something simpler, even something that you may need in another community that maybe isn't so high cost but could really meet the needs of the community. And these special interests are really keeping that from happening. What do you think, Naomi, on this issue? What do you think is the really big reason that we so need to make these certificate of need laws permanent?
The flexibility that's been provided under the emergency authorizations, both at the federal level and through the states, is really important because it really goes to show that good policy is good not just during a pandemic, but it's really good all the time. The velocity of change that's occurring in the healthcare system right now is increasing, and it's increasing very rapidly. Certificate of need is one part of what's going to be required to reimagine the hospital setting. This is one area where the COVID-19 crisis is really accelerating that need. When you take a look at reimagining hospitals, what their offerings are, how their payments are made, and how you can harness technology to really accelerate and meet the needs in those communities, particularly rural communities where we're seeing the most disruption, it really is going to require not only taking a look at certificate of need, but also taking a look at, for example, insurance commissioners in the states. What I'm seeing is, in order to get around certificate of need laws, and from the provider side, particularly specialty medical clinics and hospitals, is they're teaming up with brokers who provide services, brokering these surgeries at a fixed price, at a much lower price in these smaller surgical centers. This is being done very quickly through self-insured health insurance plans. These are the large employers around the country. They're actually now figuring out how to get around these certificate of need laws, where an employer has the analytics to look back to know exactly how many rotor cuff surgeries they're going to need, how many knee replacements, how many stents. Based on these analytics, they're able to buy in bundled packages the surgery services necessary, thereby getting around the certificate of need laws in the states, also saving those self-insured health plans money, the self-insured health plans enormous amounts of money, which is benefiting the bottom line of those large employers. So when we take a look at what's needed and what's next, we absolutely need the flexibility. We need to remove the certificate of need laws, and the flexibility that's actually provided right now doesn't go far enough. What those flexibilities provide is for existing providers to add beds, add technology. What we need is a permanent reform where we're actually removing the requirement altogether. The Goldwater Institute engages on this issue in a number of ways. For example, working with state insurance commissioners who in some cases will try to block the bundling of these pre-purchased surgeries under, they're arguing that these insurance plans are outside the law, which is absolutely not true. We also do it through litigation. 21 states have anti-monopoly clauses in their state constitutions. State constitutions can actually go above and beyond federal constitutional protections, and we use that in order to battle against the certificate of need laws. And of course, we also engage in numerous states around the country, testifying and providing intellectual ammunition on these terrible laws. But the bottom line, though, is that what we're seeing now, and what we've been seeing all along, but what is now being accelerated, is this idea that we know that the regulatory structure that governs the healthcare system is outdated. This was a regulatory framework that was developed decades ago, and it is not consistent with the medical innovations that we see today. In order to truly unleash the potential of healthcare innovation, and that includes facilities like hospitals, we've got to remove these to really make the ground fertile for further reforms. Now, we know that innovators are moving forward anyway. They're not waiting for permission. Like I mentioned, this derivative market for pre-planned surgeries is just but one example of getting around the certificate of need laws. But what we do know is that we have to focus on what 21st century medicine should look like. And that's where I think the role of the Goldwater Institute, as well as our Liberty colleagues around the country, really have to work on, is figuring out how to remove these obstacles. Sometimes it's going to be different tactics. Sometimes they're legal tactics through litigation. Sometimes they're statutory. But removing these obstacles so that the ground can be fertile for the innovators to come in and really reimagine the healthcare system. There's not one model. There are multiple models, and we want them to flourish and we want them to compete. We know that we all have different healthcare needs and preferences. We want those met. And now that we're in a crisis situation, we now have the proof of concept that we've been doing the right laws, passing the right laws all along, passing the right policies. We are now going to leverage this, and these lessons learned moving forward in order to really deliver on the promises of healthcare access and affordability, as well as innovation that we know is just waiting to come out and thrive.
Thank you. That's fantastic. Okay, so more innovation. I love it. That's what we need, more innovation. And also innovation because every community is different, right? And so every local community needs something different, and a rural community needs something different than an urban community. So it's innovation for not just innovation's sake, but for people's sake, and for meeting the needs of people, and for not causing unnecessary death and unnecessary sickness because we're stifling the ability for these people's needs to be met.
Well, absolutely. I mean, today we have treatments for N of 1 clinical trials. What that means is it's not just a personalized medicine treatment. It's a treatment for me as an individual, or you as an individual, based on your own personal genomic sequence, tailored just for you. The idea that there are restrictions on getting a medical consultation from your smartphone is absolutely absurd. Why is any government standing in the way of, a reasonable agreement between an individual patient and a physician? Right now we have rules in place in some states that say that you can't do a telemedicine visit or consultation if you haven't had direct face-to-face contact with that patient beforehand. That's absurd. We're in the 21st century. If we can have N of 1 treatments for individuals with rare diseases and cancers, why in the world can't you get a consultation over your phone?
To get access to these specialists who only one specialist in the country may know about this issue. So why can't we talk to that person? And that brings us to the last issue that we want to dive deep in. And I think pretty much everybody probably now is familiar with this and has had firsthand experience, and that issue is telemedicine. And in some ways it's perhaps one of the most exciting developments that we're seeing. I'm going to ask Charlie and Naomi to talk about this. Charlie, can you start us off by just framing this a little for us?
Yeah, sure. Yeah. So telehealth technology refers to a wide variety of IT technologies that allow providers to remotely deliver healthcare to patients. So this can refer to something as simple as a physician remotely consulting with a patient through Zoom or a Skype call. But this can also refer to technology that allows physicians and hospitals to actually connect patients with personal medical devices so that they can remotely monitor their conditions 24/7 from the comfort of their own homes. And interest in telehealth has really skyrocketed among patients and doctors as the coronavirus has spread. So patients have become incredibly worried about coming into contact with the virus. And providers are incredibly worried that they could spread the virus to a non-infected patient after they treat someone that does have the coronavirus. So demand for this has really skyrocketed. There was one study yesterday I saw that found that in some states that have been hit by the coronavirus the hardest, demand for telehealth has actually increased about 15,000%. And something that's really been elevating this has been a lot of reforms that have been coming from the Trump administration to really wipe away these barriers to allow providers to remotely deliver care to their patients. So before March of this year, the Medicare program actually prohibited healthcare providers from delivering telehealth services to patients if they weren't located in an area that the federal government considered rural. In addition, the Medicare program even prohibited patients from receiving telehealth services if they were in their own home. So these laws actually required seniors to leave their house and then go to a specially designated healthcare facility if they wanted to remotely talk to another physician located somewhere else. So thankfully, the Centers for Medicare and Medicaid Services actually used the emergency powers that President Trump announced in March to wipe away these barriers. And they've actually gone even further and announced that Medicare will now reimburse healthcare providers that deliver healthcare to patients outside of the state that they're licensed in. So this reform would offer enormous benefits for areas that have been hit hard by the coronavirus, like New Jersey and New York. These areas were absolutely devastated and were overwhelmed by the number of patients that got infected, and they didn't have enough doctors and nurses that were licensed in those states to treat them in a timely manner. But fortunately, Medicare's new policy empowers healthcare providers from other parts of the country, areas like Western states and Midwestern states that weren't really facing the same high level of COVID cases, so that they can use this new flexibility to remotely treat patients in those most affected areas. But in order for this policy to really take effect, state lawmakers need to change their licensing laws so that out-of-state doctors and nurses have the same legal authority to practice medicine within their states. And states have a real role to play in doing this. When this crisis began, AFB actually sent a memo out to governors around the country, urging them to waive their licensing laws so that providers from other states could practice in their own states. And as Naomi mentioned, a lot of states have been taking up this challenge, and they're really removing these barriers. And it's really allowing this new technology to flourish and help patients.
But one thing I would just add to that is actually 36 states created executive orders just to expand telemedicine. So the ground is fertile for it. I mean, 72% of states made action towards this. So it's been a huge sea change.
Mm-hmm. Yeah, it's incredible.
But if I'm understanding you correctly, that these licensing and telemedicine are inextricable from each other. They kind of both have to be done in some of these states for us to really get the traction we really want on telemedicine.
Well, I think that when it comes to telemedicine, I think that there are several strategies that will have to be employed simultaneously. The first is the Centers for Medicare and Medicaid Services are operating under a public health emergency that was declared by Secretary Azar in January. And this allows telemedicine to be delivered by waiving not only payment policies under Medicare, but also privacy rules. And so this is temporary. The Department of Health and Human Services just came out this week and basically said that in order to make it permanent at the federal level, that it would require congressional action. They don't believe they can do it through a presidential executive order. So that is one aspect of it, but it's not the only, but you know, that's not the only one. Whenever we take a look at the reason that the adoption and demand has increased so dramatically, it's because states and particularly private payers follow Medicare reimbursement policies in order to develop their own. As soon as Medicare issued these flexibilities, we saw a lot of the private payers waive the payment for telemedicine visits. We also saw a lot of physician offices adopt the platforms that they needed to use in order to deliver telemedicine, even though some of the privacy rules were waived, not all of them were. And so these platforms are specific to healthcare. There are providers out there that sell their platforms. So these physicians were, and medical practices were more able and willing to make the investment in these platforms. Of course, for individuals, it's in everyone's interest to continue to distance, and so that was part of the reason too. And then we also know, because working with state insurance commissioners, that there was an ability for state insurance commissioners to also issue rules simultaneously that basically said that and this is a combination of both federal and state action simultaneously working together. But at the state level, the insurance commissioners basically said, we're going to follow the federal guidance and temporary guidance under the emergency and allow for people with high deductible medical policies to not count telemedicine visits. They don't have to meet their deductible before they do a telemedicine visit. They can just do it outside their deductible. So that was also something in the insurance area that was waived. But the reason that telemedicine is so incredibly important and why this is a moment in healthcare policy that I think it's really not possible to overestimate the importance, is that the genie is now out of the bottle in terms of telemedicine. Whenever you are delivering healthcare access in an affordable and convenient manner to the patient, you are meeting the patient where their needs and preferences are. There is no way you're going back. Anytime you have a healthcare innovation, you can always test it through the lens of what does it do for the patient? Is it easy, convenient, affordable? Does it provide value? We know from experience from telemedicine already through services like Teladoc, even when it wasn't covered by insurance or direct primary care, which is like a gym membership for primary care health, which I use, that even if your patients are willing to pay out of pocket, they're willing to pay with after-tax dollars for healthcare if it means that they don't have to go and wait in an urgent care facility for 2 hours so that their kid can get their, to see if they have an ear infection. So we know already that there's a lens through which to evaluate the effectiveness of a potential reform. We know that telemedicine is at the top in terms of what patients need and want, and there's no putting this genie back in the bottle. But in addition, telemedicine is also going to be incredibly important when we're reimagining hospital care delivery. When you consider, for example, that Mercy Hospital in St. Louis has a remote ICU that has 24/7 connectivity to patients who are in their homes being monitored through a variety of ways. They have audio and video feeds constantly with access to doctors and nurses, and AI is able to flag when there is maybe something wrong, when intervention is needed, well before a human physician or nurse would be able to detect it. So the integration of AI with telemedicine is going to have really important implications for healthcare going forward. We also know as more senior, as we have an aging population and there are issues around long-term care, we know that this is also going to be part of the solution here. We have a lot of opportunities that are not yet realized, but that are ripe for moving forward and for expanding and flourishing. And telemedicine is probably, in my opinion, my estimation, the most important one. And think about the delivery of care in rural areas where you don't have specialists. Those individuals, we already know that if you have cancer, particularly a rare cancer, or if a late stage cancer, that if you can't afford to get to one of the nation's leading cancer institutions, that you will have a very different level of care, very different level of access to treatments. That can change dramatically with telemedicine, and it's already changing, and we're already seeing it with the clinical trial process being moving to more remote areas around the country. But telemedicine is part of this solution as well. So the potential for delivering the right care to the right patient at the right time is going to happen, and telemedicine is really at the center of how this is going to happen.
Thank you. Thank you, Naomi and Charlie and Kathleen. So, to make all of these policies real, we know that we need great advocacy We need great grass tops advocacy. We need great grassroots advocacy, and we need great messaging. And we have another representative from AFP here who's an expert in all of those things, and is going to tell us about some of the really unprecedented ways that she has seen COVID create opportunities for coalitions that are not just bipartisan but nonpartisan in nature. Beth Ann, are you still on our call?
I'm still here.
Can you tell us a little bit more?
I'm still here.
Good to see you.
Thank you so much for having me. This has been an exciting conversation because it's one that our teams have been having across states for a number of years. How do we drive the public discussion to get these reforms in place? And while we talked about some of them as independent reforms, I was thinking as Naomi was talking about how much they work together. So because of con laws, folks in a rural area may be several hours away from a hospital that they need to visit, but because of telemedicine laws that are in place in a state, they also couldn't be using telemedicine. And with COVID, we've seen so many of those regulations roll back. And as Naomi mentioned, that means now people have the opportunity to utilize medicine and healthcare in a way that they haven't in the past. And I don't think there's any going back. But what we have seen across states that is very, very exciting is these are issues that you really can build very broad, nonpartisan coalitions. So our state teams have been working with providers, whether they're nurses or doctors, or our West Virginia team, for instance, has been working with a nurse midwife who has been trying to establish pop-up birthing centers, which would have been great during COVID when a lot of partners were kept out of the hospital because of COVID protocols. But the con laws in West Virginia have kept her from being able to innovate her own business that way. So she sees this conversation as a way to kind of break through some of those regulatory barriers that had been holding her great idea back. We have seen, nurses really come to the table and say, hey, listen, I'm not under the current environment able to work up to my training. And I'd like to be able to do that because I think I've got training and services to share, and state regulations are limiting me there. So while we rolled some of these back under COVID, these coalitions have been building across states for quite some time. So if you think about how some of us maybe approach this, and as we listen to the conversation today, a lot of cronyism and regulatory reform that is part of some of the changes we've seen. But for groups who are not normally aligned to get sort of a nonpartisan coalition, there's also a lot of excitement around some of the innovations that we've been talking about, some of the opportunities to provide healthcare services to communities that have been where those services have not been able to meet the needs of citizens for a number of ways, whether those are urban settings and in some of our largest cities, or rural settings where folks just simply do not have access to the doctors and the care that they need. And so what we know when we bring these coalitions together and then go into legislatures is having that group of patients and providers and nurses and folks with a lot of expertise in delivering healthcare come together and have this conversation with their lawmakers. We're able to break through some of the partisan divides that keep even the best ideas from moving forward a lot of times in our state legislative session. So this is a real exciting policy space because there's a lot of opportunity. There's a lot of opportunity to build coalitions that have never existed before. There's a lot of opportunity to bring new voices to the table to break through some of the old status quo conversations we've been having that have held us back from moving forward, whether it's at the state level or at the national level. So we're seeing in our states right now, Tennessee, for example, this week is working to move both a telehealth bill and a certificate of need reform bill. And they are finding this conversation to be a better one to have in this environment, because everybody can understand how, gosh, we'd had these regulations in place. We thought that they were necessary, but it turns out they're probably not. Our Colorado team, which had been working on a number of healthcare issues, they got a call from a lawmaker they had not traditionally worked with, who said, hey, listen, I think we've got some agreement on this, and I'd like to sponsor a bill. So let's sit down and have a conversation about that. Our team in Virginia has been working for years across changing political landscape and the partisan divide there, and have been able to move a lot of these issues forward, including telehealth, even before COVID became an issue. And so that prepared Virginia, at least, they were better prepared. For a number of states didn't have to go through the process of making those emergency orders, because they had already adopted some of these laws, and the team there is continuing to push forward. So, if you're somebody who loves to be involved in the political fray or the legislative fray, this is a great issue to participate in, because it is a really broad, nonpartisan coalition. It's always exciting to have the opportunity to sit at the table with new faces and really drive the kinds of reform that can be transformative and impact everyday citizens. So really exciting time. We're continuing to work through our Healthcare Reimagined campaign to push these reforms, as everybody has talked, to make those temporary reforms permanent, and then continue the discussion from there. There's a lot more we can do.
Thank you. Well, this is great. We are kind of reaching the end of this incredibly rich call that we've been able to have. And I do want to ask if anybody else, any of our participants on the call, have additional questions they want to direct to our panelists. Now is the time to do it. We wanted to kind of close this session and have everybody come back and come together. And we wanted to kind of ask the question, how does philanthropy really fit into this whole effort? What can philanthropy do, to advance and to really make permanent the innovations that we've been talking about today? So I asked each of our panelists to think about. I asked them, can we just at the end do a lightning round? And could you kind of just present, quickly, one actionable project that you think that could be most impactful right now, something philanthropy could support? And we will follow this up with an email as well to those who have participated, so you'll get more information on this. But I just wanted to give each of our panelists a chance to talk about that one project they're most excited about. So Kathleen, can we start with you?
Absolutely. I'm so encouraged from everything I've heard today. I mean, this is really an all-in moment, with that goal being, how do we drop the demand for nationalized healthcare, but also build up these free market reforms and innovations, so people, so to speak, taste the ice cream, right? They know how good it feels, and I think we're seeing a lot more of that. One of the things that I'm really excited about that we're working on at SPN, where we are launching an initiative. We're working so fast we haven't even named it yet, but it's this idea of what are those messages that are going to resonate with Americans? How do we know where they are so we can speak to them, right? Because it is going to be an all-in. We need Americans to make this pivot for these reforms to convert. They have to demand it. Right? With any kind of legislative change, when the people demand it, it happens. So we're going to be doing a deep dive into messaging, deep dive in how do we combat this nationalized healthcare message that we've been getting. And then it's really a big going into legislative sessions in 2021 in full force, making the case to keep these permanent.
And you'll have more information that we'll send out on that initiative.
Yeah, have a lot
right?
Absolutely, yeah, we'll send it to you, Anna, and we'll get out to everybody.
Charlie, what do you think could be most impactful right now?
I think what would be the most impactful right now is to really look into the think tanks and the academics that are really diving into what all of these reforms are really doing to our healthcare system. How are they helping, deliver better care, deliver better medicine, really expand access to patients? I think there's going to be an enormous demand for studies to really look at how has this sea change in reforms really helped patients. And that's going to really help activists like the State Policy Network and Americans for Prosperity to really bring this data to lawmakers and really show that there is a better healthcare system out there and we can really deliver it. And this is going to be a really great pilot program, so to speak, to really show these benefits.
So national think tanks, academic centers, just
Absolutely.
get the studies out. Great. Okay. Yeah. What do you think, Beth Ann?
Well, I tend to think a little more local and community related, and so I think that something that might be valuable is to look around your local, the state where you happen to live, and kind of understand what those innovations are, how you can potentially bring that academic and important research down to the local level so that folks are being able to connect and make it actionable, because those are the voices on the ground that we're going to want part of this discussion. I think there's a physician in Pittsburgh who opened up a flat rate $39 fee clinic, right? And so I think that's kind of exciting activity. It's unique across a number of different states. He doesn't take any insurance or anything like that. So finding those local opportunities to connect locally with groups who are interested in these issues are great, because we need to also help elevate those community voices that need access to all of these new solutions.
Naomi, why don't you bring it home? What do you think?
Well, thank you to Anna and Alyssa for organizing this call and for inviting me, and to my Liberty colleagues who are also on the call. So the Goldwater Institute very early in the COVID-19 crisis recognized just how broad and deep the impact of this crisis would be, but also what kind of opportunities it would provide to show and demonstrate why good policy matters and why it matters today and why it's going to matter tomorrow. So we immediately embarked on creating a toolkit for state lawmakers that covers economic freedom, education, and healthcare. Under the healthcare area, we dive into several policy areas. We also provide model bills to accompany those reform ideas. The Goldwater Institute secret sauce, if you will, is that we provide thought leadership. We have an incredible team of legislative strategists. We also provide technical assistance on tailoring model bills, because we have a large crew of attorneys on our staff. And we also back up our model bills. If a state passes a model bill and there's litigation around it, or the state's not implementing it, we will go to court with those lawmakers to make sure that that law is defended. We provide that at the Goldwater Institute. We will go to court with you. And so we will be releasing this in the next 2 to 2.5 weeks. If anyone on the call would like an early advance briefing on this policy toolkit, we would be honored to share that with you and see if you're interested in supporting any of the ideas contained in that toolkit. It's very broad, like I mentioned, but it does focus on healthcare. And we really do, most importantly, our goal is to make sure that the right patient has access to the right treatment at the right time. These reforms are critical to doing that and to really unleashing the potential of innovation, removing obstacles and barriers and red tape, so that we can actually deliver on those promises of healthcare access and affordability, and we can do it now.
Oh, thank you. Thank you so much to our participants. Thank you so much to our panelists. This is great. I thank Charlie, Naomi, Kathleen. This was terrific. Thank you. We really want to hear an update soon, and we wish you Godspeed in all the work you're doing.
Thank you.
Yeah, thank you.